tumor stages and different tumor grades have got different survival outcomes based on response to therapy and ability and sites of distance metastasis. Now, the biomarkers, estrogen receptor, progesterone receptor, herceptin receptor, these biomarkers are critical. In fact, it is recommended for every positively diagnosed breast cancer, these 3 markers have to be done. Yes, we understand their limitations because they have to be paid for. They are not part of our routine care. And I believe that part of the universal health care is to at least to make these prognostic indicators available readily to help make a patient who walks in with a tumor not to come in with a label and leave with a label, but to live with some prognosis behind how they are going to benefit from available treatment. And therefore, accurate testing is essential. Why? The king must be treated well, okay? And we are cognizant behind the scene that we can have false positives and we can have false negatives in ER/PR, but of course there are controls, there are standardized guidelines that if they are observed by the surgeons, providing the biopsies by observing cold ischemia time. Remember that a biopsy should reach the laboratory within the first 1 hour and should be fixed immediately. Otherwise, an unfixed tissue, these biomarkers, because they are very delicate surface proteins, they tend to undergo degradation. And the reporting of the ER/PR is quantitative, is semi-quantitative, because we look at the intensity and also the distribution of the staining. That means if, let's say, an initial biopsy from the patient had, let's say, an RED score of 8, because that's how we look at it. And because of delayed fixation time, the patient presents with a reduced RED score. That might shift the diagnosis, let's say, from one subtype, let's say like alumino A to alumino B, which have got totally different prognostic outcomes. Again, extended formalin fixation is not encouraged. We can say it's a no-no, but we know we are working in very challenging environments, but we recommend that fixation time should not be more than 24 hours, but if extended, at most not more than 72 hours. Otherwise, after that, again, the tissue will undergo the same degradation. Okay. As a variables, incidentally, these luckily have been standardized by the AJCC, and with internal and external controls, correlation with histopathology, that is, and again, reporting has been standardized. When you look at grade, see this one, okay. When you look at the grading, yes, I know not everyone is very comfortable with histology, but you can see this basically is a gland with lumens, and you can see it's basically forming a nice acina. When you come to the bottom, it's formed a syncytium, a sheet of cells. So remember, grading is based on the degree of differentiation. While differentiated, that means tumor resembling the primary is graded as a 1. Progressively, tumor that has totally lost the morphological phenotype, almost forming sarcomatous-like, is a grade 3. And you can see very poor before the era of systemic therapy. The prognosis was generally very poor across the 3 grades, with medium survival time, can't see very clearly from here, going down very fast. But now with the era of systemic therapy, my previous presenter has mentioned that it's very, very good depending on the number of cancer cells one is killing with chemotherapy. And this has there's a paper to that effect. Going on is the grading plus the the biomarkers help us to understand, or not to classify. So that is one of the prognostic benefits of ER, PR, HR application is coming up with morphotypes that have been correlated with the genetic or biological activity, the rate of replication, likelihood of responsiveness to chemotherapy, and overall outcome. So these 3 subtypes, lumino cancers, so we have lumino A, lumino B, triple negative breast cancers, and HER2 cancers are one of the benefits of using the biomarkers. Now, I want to introduce something about the AJCC. Initially, we were using the 7th edition. Now we have got the 8th edition, which is mandatorily should be used with effect of 1st January 2019. We are no longer using the 7th edition. Reason is the current AJCC is a major shift, has brought about a major shift in staging, whereby now we are using the biomarkers, PRER, HER2 as part of the staging system. So that's the second benefit of using the ER, PR, the so-called biomarkers, that besides having the grades incorporated, the overall staging from TNM anatomic-based, the prognosis-based staging now incorporates the biomarkers. And all cancers, other than the sarcomas, the phylloides, which are basically stromal tumors, are staged using the AJCC. And it's a document that is available for use by both clinicians, pathologists, oncology, and everybody in the multimodal and multidisciplinary team. Downloaded downline, some may have to be purchased, but I think if you work with Dr. Abdulaziz here, with myself, we can give you some physician-friendly copies that are freely available online. I'll rush through the anatomical staging, which was the previously being used to give us just these 4 stage groups. And again, this is a prognosis survival curves showing that stage 0, stage 1, or the low burden cancers have got better survival across the years, but very poor survival for stage 4 tumors with distant metastasis. This is just re-emphasizing. Already my 2 messages are that ER, PR, the biomarkers are giving us biological predictable tumors, the luminous, the HR2 triple negative breast cancers, and that they have been incorporated into the new AJCC staging system. This is just another to show that by use of the biomarkers, a tumor that is, let's say, like stage 3, just by the label, can have different survival times simply by incorporation of the biomarkers, to the extent that luminal cancers, which are better differentiated, better prognostic, with addition of ER positive but HER negative, have got better survival compared to those that are triple negative. Triple negative is a poor prognostic outcome. HER2 by itself is a poor prognostic marker. Therefore, ER positive, which is a very strong positive prognostic marker, in absence of poor prognostic markers, can vary an anatomical stage to better prognosis, giving better promises. So many slides moving very fast, but it's basically the same message, that now the AJCC classification can be used both by the clinical team and the pathological team. What are we saying is that science has brought us together. We are now coming under the reign of one king, the biopsy, saying that we can have consensus terminology. The clinical oncologist saying this is a stage 1 tumor, surgical oncologist saying this is a stage 1 tumor, is the same language a pathologist, having looked at probably a mastectomy, will say this is a stage 1. We all agree, and therefore, how do we group our patients based on survival outcomes, prognostic markers? And just to emphasize, something new about the current benefits of the new staging system is that it has reassigned the traditional anatomical categories, that 30 to 40% of the patient, you can imagine nearly half of the patient are being reassigned, you know, whereby we are just using TNM with no benefits of the biomarkers. But today, using biomarkers, we are reassigning patients, and just about a quarter of them we downstage, a few remain in the same stage, and a few upstaged, and those that are upstaged are the poor prognostic tumors with HER positive and triple negative breast cancers. And to say that it is level 1 evidence, yeah, as we said, AJCC does not make guidelines, it only reinforces that which has been observed through cohort studies. And there are several publications to this effect we can share with the team, comparing pathological staging and anatomical staging. And for the students who are here, I can see a few postgraduates. Most of us are also supervisors for projects. This is a very good thing, yeah, that you can look retrospectively to breast cancers that have been treated over time. And since now, I've been working closely with most of the oncologists from Mombasa and wherever else, that if now you have to incorporate the biomarker guided staging, what kind of patients are we having? And you realize that most of them probably may need downstaging, but they've been lost to follow up because of certain logistic issues, concerns. Just to say that cancer diagnosis is a continuum. The clinical staging starts with the moment the patient walks in, diagnostic workups, physical examination, imaging, and then the pathological staging is where surgery is the first entry. But the message is we reassign the staging, only that we need to put a prefix, whether this is a pathological stage, clinical stage, post-treatment stage, and even at times stage after a recurrence. And I think I'll need to stop there. The rest are just papers that we can share freely. And just add a mark that currently there is a path towards using genomics to stage patients. There are several gene-based protocols like MammaPrint, Oncotype, but they have not been validated for routine use. But if you have a patient who can afford, it's a good entry point, particularly for low burden tumors. Yeah? Stage 1, stage 2, ER positive, PR negative, HER negative, but I just need to say that use the anatomical staging TNM, and then you amalgamate all the other findings. What is the grade of the tumor? Using microscopy, biopsy is king. Then the HER status, ER status, PR status, and you can see for certain very high grade, even high grade TNM groups with not so favorable morphology being downstaged from stage 3A to 1B purely based on positivity of the PR status and ER status, whereas those that are ER negative actually remain the same. Similarly, for again grade 2 with PR positive, ER positive being downstaged, yeah, from 3A to 3B at 1B, yet you can see some of them actually qualify to be stage 3 tumors. So there's a benefit on asking and using the biomarker profile. So in summary, TNM is no longer acceptable by its own, and all patients prior to treatment should have a clinical prognostic stage calculated. Use as much as possible both clinical and pathological staging, multimodal approach, and lower stage disease reflects favorable biology, effect of therapy, or both, and therefore you can use this classification to triage patients who are likely to benefit from either chemotherapy, hormone therapy, or Herceptin receptor target markers, and those who you can just tell, sorry, I think we sympathize, all we need to do is palliation. And therefore, a glimpse into the future is the more advanced staging as we understand the sciences, and that these updates of the grading system are likely to come more sooner than the traditional 6 to 8 year cycles, because we are understanding much more. So thank you very much for your audience.
Thank you so much, Dr. Albert Gashao, on this, the role of biomarkers in breast cancer prognostication. So just a quick reminder from Dr. Bajabir.
Yes, there are a few questions, two actually. Question to Dr. Riaz. I understand, you finish here? Okay. So we'll take the questions after the last speaker probably. So we do the 15 minutes. We do the 15 minutes. Okay.
So, okay, thank you. We'll do the question after the last session, and I think the last session, I don't know. I just want to ask you a question. Do you have the data of the registration? How many medical students are here? medical students. Okay. I think the trend is not really good, because I remember during our time we were really active in Saun. I don't know what's really happening. Is it the issue with the registration incentive, or yeah. And because some of these topics are really targeted to, especially to the medical students, and also for those who are done with their undergraduate training, so that they can choose right career and also to get exposure to different specialities. So I think, I don't know where the problem is, where the challenge is, but I think, yeah, it's one, yeah. So now I want to welcome Dr. Ali Kasim. Ali Kasim is a clinical pathologist working in Metropolis Health Laboratory, and I think he's the is the deputy African in charge. Basically, he oversees lab in Kenya, Zambia, Nigeria, Uganda, and it's a small world, because I joined the MEd program 1 year earlier than him. And he was so interested in doing pediatrics. So then he came and say, what about pathology? So I say, yeah, it's a good program. You can try. And he said he want to be a clinical immunologist. I don't know if he's still practicing clinical immunology, but he'll tell us more on the role of clinical pathology in patient care. And I think I'll just suggest to Dr. Ali to make it as more interactive, because I know this is a very critical time where concentration is almost zero. Yeah. Thank you. Welcome.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. I have two things first. First, I'm honored to be standing in front of some of my seniors and mentors. It's really a great honor. Secondly, I'm probably not in your good books right now because I'm standing between you and tea. So please just bear with me. I apologize in advance. So, yes.
There's no, like, guys can go and take tea and come back. And I think they can also pass at the exhibitor, just a quick one. But I think people can go and pick their tea and come, for those who haven't. But I'll prefer just stay and listen to this last presentation.
Okay, thank you so much. So I'll try and make it a bit interactive, because my mode will be a bit of case presentation. I'll not be covering a lot of cancer diagnosis, but I have a case or two about that. So my scope will be looking at this. So what is clinical correlation? How many of you have seen that comment by a pathologist? Correlate clinically. What does it mean? What is pre-test probability? Lack of standardization, comparison of lab tests across labs, across methods, and sensitivity of the tests that we're using. Okay, my first case is this. So these are real cases that we've had. A 2-year-old term newborn with duodenal atresia. Okay, a 2-year-old newborn with duodenal atresia is prepared for surgical repair. So the pediatric surgeon comes in and says, let's run these few tests first. So this is how the tests look like. And right at the bottom, what is there? INR of 8. How many? Give a go ahead to the pediatric surgeon. He calls and says, can I go ahead? Can he go ahead? Why not? But why?
Risk of bleeding.
Risk of bleeding, okay. Why? Why does the patient have the risk of bleeding? Because the INR is 8? Does the patient have, the child have coagulopathy or anything else? Okay, so because of time, I'll rush through it. Can you notice the HCT there, the hematocrit? What is the hematocrit? 65. It's a newborn child. How was the blood collected? How many can say they struggled to get blood in this patient? Most likely, right? What tube was it collected in? Okay, microcuvette. Was it filled? Was the microcuvette filled? We were all interns at some point. How many of us were asked to fill a tube and they said, no? I mean, I'll just do halfway. This is adequate. How many? How many did not fill a tube? We all did that, right? So, and it's very important. There's what we call the anticoagulant to blood ratio. It is very important. And here there are two issues. If the anticoagulant to your blood ratio is not adhered to, then you can have a problem with the anticoagulation. You may not get enough anticoagulation, and that will affect your coagulation profile. But most importantly in this case is that the hematocrit is on the higher side. And you'll actually get babies with much higher hematocrit. So how much is the plasma in that? If the hematocrit is 70, how much plasma? Pathology, eh? You didn't like it. How much plasma? About 30%, right? Now, the coagulation, because here we're talking about coagulation profile, the sample is 30%, and you're using the same amount of anticoagulant in that tube. So the ratio is not the correct ratio. So for this case, what we did is we actually went ahead and calculated the amount of anticoagulant required for that hematocrit, and we repeated the INR, and the INR was 1.2. And the pediatric surgeon was happy. He went in, did the surgery. Unfortunately, after the surgery, he came back and said, Doc, can I get that special tube and repeat the coagulation again? I asked him, why are we repeating? He said, I want to see whether it's still normal. But I said the patient did not have a problem. The problem was just the pre-analyticals. You know, the patient is fine, so you don't need to. How many of us monitor anticoagulation after surgery with a patient, in a patient with normal INR? Do you monitor your INRs after surgery? So again, very important things to understand that these are some interactions that you have. Sometimes you don't send away the patient. You may want to have a talk with a clinical pathologist and say, what could be the cause? And then you discuss. You find out sometimes the tube was brought in, it was only a quarter way. And that is affecting your coagulation profiles and so on. So some very good discussions can actually occur, and then you can get some help with that. Second case, quickly. This is a 28-year-old with fever, chills, and dark urine for 3 days, traveled to a malaria endemic region. Examination was unremarkable. The hemogram looked like that. I mean, I don't have enough time, but there's a lot of discussion that we can have about a hemogram. Yeah. Okay. Always, I'll just say, always look at absolute differential counts. Don't look at relatives. Okay? If your lab is not giving you absolute, ask them to give you absolute differential counts. Do not treat don't say a patient has neutrophilia because you know the relative count says 80% neutrophils. What if it's 80% of 4 total count? Yeah. So that's just something to mention there. But I'll move on because of time. This is the urinalysis. So it looked like this. How many can guess what's going on with this patient? Just quickly. Anyone can shout? So patient has bilirubin 3+, blood 2+, urobilinogen 2+. Everything else is not so remarkable. How many? Yes, doc? Hemoglobinuria. Okay. Why? In the specific case, why differential? Okay, so red cells are nil. So most likely the blood up there is hemoglobin, maybe. Not red cells, okay? What else can cause that positive blood there? Myoglobin, I think we have very experienced people around, but you always have to think like that, yes? How about the bilirubin? What is the cause of that? Hemolysis. So differential? Differential? In this case, patient with, that's your differential, top differential. Exactly. So that's exactly what happened to this case, and the patient was given antimalarials and sent home. Luckily, we actually, it was an interesting case because it was a fellow doctor. So he came to us and we looked at the report and we said, no. If you find bilirubin in urine, what is your first differential? Actually, hemolysis is not a differential of bilirubin because which type of bilirubin is found in urine? Which type of bilirubin is found in urine? It's direct bilirubin. Most of the time, if you find bilirubin elevated in urine, it's direct bilirubin, and it should tell you a liver issue, not hemolysis. Hemolysis gives you an indirect bilirubin, so you won't find bilirubin. You'll find urobilinogen elevated, but you will not find bilirubin. So in such cases, always think. So this case, the patient was given antimalarials and given paracetamol and everything and sent home, and immediately we just asked him to do, what? We've said liver, right? So we asked him to do liver functions. And look at that. Look at the AST and ALT. Has anyone seen ALT, AST that high? Right? I mean, and then we went ahead and said, and this happened in a time patient had come to Mombasa, and there was an outbreak of hepatitis A in Mombasa at that point. And the patient was hepatitis A positive. We stopped the antimalarials and the paracetamol, which could have even damaged that liver, you know. So those are things to think about. I mean, and that's what clinical pathology does, that you really think about the test. The test is not just a test. You don't send a test request to a lab without knowing what the lab does. What methods do they use? And knowing what methods a lab uses, it will tell you what it is able to pick up. And then there, you'll be able to now come back and say, okay, this is probably the causes of what I'm finding from the lab test. So a different case, urine culture for a 40-year-old female with cystitis, organism is E. coli, that is the susceptibility pattern. Which drug will you put the patient on? Physicians, obstetricians. No right answer, no wrong answer. Trust me. You put the patient on ceftriaxone, right? I would have done that if this patient came to me as an MO. But then there are things that you need to think about. Ceftriaxone, there's cefotaxime there that is susceptible. There's ceftazidime is resistant. Which generation is ceftazidime? Pharmacist, our dear pharmacist. Okay, it's third generation, okay. So why is ceftazidime resistant? Why is ceftriaxone susceptible? You need to ask these questions. Now, ceftazidime, actually these cephalosporins most of them are used as indicators for ESBLs. ESBL is a mechanism for resistance for most of these bacteria, yeah? Ceftazidime is an indicator of resistance for certain classes of ESBLs. So it's a better indicator for what we call TEM and SHV modes of ESBL production. Yeah? While cefotaxime is a better indicator of CTXM mode of ESBLs. Yeah? And in such cases, you would not give ceftriaxone, you would not give cefotaxime, because likely this patient has an ESBL producing E. coli. So you would call the lab and ask them to give you, let them do other tests. Let them do carbapenems and other tests, yeah? So you really need to look at this. And for labs that have clinical pathologists, these reports are usually moderated. So that then the clinical pathologist would go through it and then say, there are possibilities that we are having organisms that are producing some resistance, and then the reports go out with some clinical interpretation or correlation, clinical correlation. Yeah. Okay. A sickler seen at a routine follow-up clinic, WBC count is 17. He has neutrophils of about 6. This is absolute. Yeah. That WBC is very high. Okay.